I want to start with a question for both of you, which is why invest in digital patient engagement? Kind of given the premise that I sort of led with of does it really affect the ROI or the bottom line of a health system? Why have you both chosen to invest here?
I'll just ask the question. How many of you remember when you had your first iPhone or first Android phone? And I said to the person, okay, where's the instruction book? And he laughed at me and said, go home and use it for 10 minutes. That's what Notable was like and what it seemed like it would be and has been for the last year for our patients. No one's needed instructions. It's been completely intuitive. We didn't have to send our training teams out how to train everyone on how to use it. And it was literally an overnight implementation. So from our standpoint, it was just that ease and that ability in 4 weeks to put something in place during one of our height of COVID outbreaks last September that we could actually help our patients so that they didn't have to come and sit in waiting rooms. They could have all of this taken care of ahead of time.
Brenda, same question for you. Why invest here?
If you don't have digital engagement, you don't have engagement. When you don't have digital engagement, what happens? Your system is consumed by the highest utilizers. And if you want to drive health equity, which we all do, you can't drive health equity if so many of your resources are consumed by your highest utilizers in the system. So you invest in digital engagement, to me, it's a no-brainer. If you're looking for return on investment, qualitative and quantitative, you have to invest in digital engagement, or else you don't have engagement of 98% of your patients and your consumers.
I want to divide our conversation up into sort of the pre-Notable, what was the environment like, and then sort of upon kind of working with Notable, how have you seen things change? How can we get better? So sort of before Notable, what were the access and engagement challenges each of your organizations faced? Just help us, help paint the picture for us of what access and engagement looked like at your system that helped precipitate that desire for change.
I can start there. So I would say the access issue, we could define it by saying inaccess, no access. Call abandon rates were over 50%. So when we partnered with Notable, it was really during the height of the pandemic. We were getting flooded with calls. We needed to do significant amount of outreach. Patients were confused. Patients were scared. Our workforce was completely burnt out across the entire supply chain, from your registration clerks through our providers. And we really needed to just really provide a little bit of relief.
Pre-Notable for us was really, I would call, an extension or a next step for us in our journey to centralize and to try to create a more consistent flow for our patients. So we had started about 3 or 4 years prior creating a centralized call center so that we could pull some of those resources and create some centralization. So I always had the opportunity to lead that over those years. And our call abandon rates, we were able to get them probably around that 10% for most clinics, but Notables obviously allowed us to bring that down closer to the industry standard of about 5% because, again, we're using top of license for those individuals, and we're skimming out some of that work through the Notable experience. But additionally, having patient experience is one of my passions by what I represent in the organization. Notable is giving us so much information we didn't have prior to utilizing them. We're getting 4,000 written comments in every 3 months. And that data it tells an entire story for our community who's giving us feedback. And many people had said, well, put that into the survey. And it's so much more valuable in that real-time moment. And it's telling us a lot. They're obviously giving us that feedback about what they care about and what's important to them. And time savings and us respecting their time is one of the biggest things. They've also quoted the clipboard of death. They're very appreciative that we got rid of that.
We hear sometimes that technology can actually worsen healthcare disparities. It can sort of further, entrench, current trends or individuals that are more likely to use it. How would you respond to that? How have you used technology to be an agent of equity?
So I would hear those arguments in within my own organization, within the space of community health, and even within our cohorts of federally qualified health centers. And so I will say that this is that if you want to be culturally competent, these are not competing forces. If we have to do both, and we have to do all. And there's this conventional mindset, really parochial mindset, that says that high touch, high engagement, and advanced technologies cannot coexist. If you want to be high touch, if you want to be relational, if you want to be culturally competent, if you want to reach the patients in the space, in the moment that you have to reach them, you have to have advanced technologies. That's where you get the ROI. That's really where your strategy comes from, frankly. And I think that we're learning how to do that right now.
Michelle, you painted a helpful picture for us of sort of the challenges you were facing from an access perspective, from a staffing perspective. How do you think of areas where your EHR can potentially solve a problem versus where you need to look elsewhere to fill a gap?
I think a few of the speakers have already said it. We love to have a one-size-fits-all, but right now that is a very heavily focused on the clinical outcomes and the clinical different needs. And this is just a different area that needs an expertise. And one of our IT engineer individuals who is in charge of a lot of our Epic projects, I know, challenged different times as far as why would we need this? Why can't we just keep using the products that we've already paid for? And I had to eventually, in one of the recent upgrades, make that tough decision to turn that off because it was conflicting to our patients. We needed more of a seamless one flow, one process for all of our data collection. And that individual herself was a patient, and she had said, "You're right, it is much more intuitive, and it's much more like what it's like in other industries in the Notable experience versus the experiences that we have purchased in our current EHR product."
And I want to say something to that as well. So for us, we didn't want to be part of another optimization project. So Notable, when we said, whatever we do, we want to do patient outreach. We don't just want it in English and Spanish. The whole world is doing that. That's not innovative. That's not transformative. We need it to be in all of our top languages. It has to be in Portuguese. It needs to be in Khmer. And this is not going to be an optimization project that we get to in Q1 or of some year at some point in time. And so if we're going to drive health equity, we have to be much more fierce, much more bold.
We've been working together with both organizations now for at least a year. And so help paint the picture of what sort of patient engagement has looked like at your organizations post-Notable. We know some of the numbers, but what are the anecdotes, the stories that come to mind when you think of the Notable experience, not just on patients, but even on staff?
I'll go first with that. I'll use our orthopedic clinic. It's one of our largest and heaviest usage clinics within our network. There are probably around 300 patient visits on a given day. So lots of hustle and bustle with a group of patients and support persons. Many times that support persons drop that patient off at the front door for them not to have to walk through the parking lot. They walk in and they're greeted by pre-Notable, a large line to check in. And these are individuals that are in pain or have had surgery and they're really not wanting to stand in this long line. That line is gone. And that is what staff will say, that has made their life so much better. They don't have to look out and see that long line and see these people saying to them with their eyes, how much longer am I going to have to wait? In addition, that staff are so much happier because they can literally start with that patient with a smile versus they're still processing the last patient that they're trying to take care of and knowing that the other individual at that point is inpatient at that point because of all the other wait times that they've had. So from a standpoint of staff, our staff feed right off of our patients feed right off of our staff. It's completely reciprocal, but that line is gone, and they are the first to tell us, unless our Brian, our product person, tells us first. They're pretty both in step to say, hey, something's wrong, or this isn't functioning just exactly right. And it's something minor. It's not even something disruptive, but they know, and they're eager to make sure everything is seamless every day.
So for us, I'll start with, I guess, our employees. The most expensive thing in any organization is the lack of ingenuity of our employees. That is what costs us the most. And so how do we inspire ingenuity? How do we inspire confidence in our decision-making and our leadership? So I think we reduced over 2,000 hours over this time. And we're just repurposing those hours and those minutes to have just better conversations, get to know our patients better. And that's what we've been doing, so.
Michelle, Brenda, thank you so much for joining us. This was a lovely conversation.
Thank you. Thanks.